The HIPEC procedure has changed in the recent years as compared to when it was first introduced in the mid-90s. One of the big differences is that we've expanded the patients that we consider for the procedure. As we've learned more over the years, we've discovered that although it was initially developed mostly for appendix cancer, the patients can have good results for other types of cancers, especially GI cancers, such as gastric cancer, pancreatic cancer, as well as colon cancer and other GI cancers. The other big component of the changes in the last few years has been improvements in the perioperative care. Now that we have excellent ICU support, specialized anesthesiologists that assist us with our HIPEC cases, we find that patients are recovering more quickly, getting out of the ICU faster, and having an overall smoother get back to their life. The HIPEC procedure, has benefit for patients that's been demonstrated, especially in colorectal cancer as well as ovarian cancer and others. That's been documented in randomized controlled trials. Additionally, retrospective experience has shown improvements in survival for patients with pancreatic cancer and gastric cancer. Most of the patients we offer the HIPEC procedure for have appendix cancer or colorectal cancer. Those are the most common indications for the procedure, and that's what's historically been most popular for it. We've also in recent years begun to identify select subsets of gastric cancer patients or pancreatic cancer patients, or even some others that may benefit from the procedure as well. So coming to Johns Hopkins for HIPEC surgery is important for a number of reasons. The first is that we have specialists here, such as myself and others, who deal with tumors in this location. And so having a specialist surgeon as well as specialist medical oncologist is very helpful in this scenario. The other thing is part of our big team approach. It's not just the surgeon that makes the difference in the patient's recovery from surgery, but actually is the anesthesiologist, our ICU teams, our nurses, our residents and fellows. All those make a big difference for the patients in their recovery, and we really think that it's that team approach that benefits patients the most. In the future for HIPEC, I expect we'll be making changes in a number of ways. One, I think, is that the chemotherapy drug that we use for HIPEC is mitomycin C, which is very effective for this treatment, but is also a pretty old drug. And so I think in coming years, we'll be developing ways to deliver other drugs intraperitoneal that may make a difference for our patients. The other thing is we'll develop more and more data, I think, around other tumor types that may benefit from this approach. And once we have firmer data there, I think we'll be able to get this approach into access to more patients. We'd be interested to see patients with carcinomatosis from cancers of GI origin, even if their providers aren't sure if they'd be a candidate for the HIPEC procedure or not. Sometimes we are able to offer those patients the HIPEC procedure, and we're happy to do that in those cases. On the other hand, for patients who aren't a candidate for that procedure, we have other trials of peritoneal-directed therapy or other approaches that we may be enrolling for here at Johns Hopkins. Our evaluation of patients with peritoneal disease for consideration of the HIPEC procedure is multiple parts, and we do it in a multidisciplinary fashion. The first component is a review of the patient's history, their imaging, their pathology results, and sometimes we have the pathology results reviewed by our expert pathologists here at Johns Hopkins to confirm the diagnosis and see how that should influence our treatment plan. Once we've made an assessment of the burden of the patient's disease and what we should expect from the surgical procedure, we also discuss the case with our medical oncologist or the patient's own medical oncologist to determine whether systemic chemotherapy or other systemic treatments may be used in addition to the HIPEC procedure.